Welcome, everyone. We're just getting everyone in and audio connected, and we'll get started.
Okie doke. Hi, everybody. I know over the lunch hour, we're just getting folks in. So I think we have a number of registrants today and folks who can't make it because of travel. A lot of health conferences right now and research conferences. So thanks for those who made it and to all of our friends who are watching this at a later time and date. Welcome as well. So thank you so much. We're going to introduce the goals of our session today, talking about what is bringing to life. I think the topics for today. Talk about we'll of course introduce our speakers, and then as we're getting ready to launch and getting folks on, if for now we can have you all put your name in the chat, any questions that you already know in advance that you're considering or thinking, so that Kelly, Dan, Elsa, myself, Joe, any of our team can help answer. That would be great. We'll try to weave that into the discussion and presentation, but we'll also have time for Q&A where everyone can come off mute and join in terms of the discussion as well. So go ahead and add your name, where you're from, town in Colorado or elsewhere. And then if you're with a specific health system or an organization, that would be great to see. So I see some of our friends from Lamar joining today. By the way, I went to the El Lamar Theater in Lamar just a couple weeks ago when the Josh Abbott band was in town. And what an amazing place. I just have to tell you, I hadn't been to that place since it was a movie theater, but it was super fun. So here's a big shout out for Lamar, Colorado, and the Eastern Plains, per usual. So, thanks so much, Ian. Many of our partners, Rural Health Center, thanks so much for joining in. I'm going to go ahead and get launched moving before, but also any other technical pieces before we join in today.
Just as always, we'll be sending out the recording and the slides within a couple days following this webinar. And please feel free, as you think of comments and questions for our presenters, to add them in the chat real time, and we'll keep an eye on them and make sure we return to them once we get into discussion. So thanks everyone for being here.
All right, wonderful. All right, so today what you've won, everyone, is we are with our two of our esteemed colleagues and one of an expert patient of sort who's been an amazing spokesperson for, I think, really the attribute of screening and sharing his perspective. We're going to be sharing in general information and data about some of the messages for primary care clinicians, our navigators, and other members of the team about ultimately esophageal cancer, Barrett's cancer, and screening, and that's the name of the game. As everyone knows, we've been doing, over the last couple of years, a series in the spring, late winter, dedicated to GI screening at large. And so colorectal cancer, gastric, as well as thinking about esophageal cancer screening. And I would say this really actually is partly because of a major investment from the Rady family and the Rady Center for us at the University of Colorado to expand the work in esophageal and gastric cancer and screening as a very lethal cancer and sometimes not quite on the radar like breast, colorectal, and others. But with CCSP, I think we've heard the cry from many of our patients, survivors, as well as our clinics and navigators about also more robust resources for looking at screening beyond colon and rectal cancer, but also for esophageal and Barrett's, as well as gastric cancer. So we're excited to look at kind of a multi-pronged prevention GI strategy. And so those series have run. So we are in the third of the trio, and excited about today having Kelly DeLay and Dan joining us, who I'll give a little more information about, but really excited about the partnership with the Rady family, CU, the funding we have from CCPD. To look at preventive cancer screening at large. And so much of the work is GI, but of course, even thinking about broadly, what are the resources for cancer screening at large for our FQHC systems? We're going to be talking today for esophageal and Barrett's about the latest medical guidelines and evidence-based interventions to increase uptake of screening, notable areas of impact and advice consideration for our primary care friends, as well as some of our community partners, and ensure the voice of the survivor and patient advocate to really reinforce the themes, the experience, but moreover, what I think we really should be considering from the end user and those who we care about in terms of thinking about what primary care providers, our navigators, and other members of the clinical team need to know about the patient experience and what are some of those lessons learned. And I would say that this work and this series is built off of the integration of more survivor advocates and community based on, I think, some of the great resources that we have, but also really, I think that many of you really wanted to hear more about how can we be patient-centric, how can we really think about do a better job of reaching our community. So I want to say, I know Dan Rathke, I met through some of the work at Rady Center, is that person. And I'm really excited that he will be joining today to talk a little bit about his experience, reflect on his story, and also his diagnosis, as well as really ultimately really thinking about his, kind of what he would recommend all of us to think about, but also sharing kind of that mantra of screening and early prevention, and that the use of different modalities can be quite helpful for patients. And as we get ready to move forward right here, I'm going to actually pass along or send on to Kelly. Excuse me, sorry, my voice cracked there, still getting over a little bit of a cold. Dr. Kelly DeLay, who is one of my colleagues through the Rady Center work and is also an associate director, but an assistant professor of medicine in GI at the University of Colorado Cancer Center, and is a wonderful person in terms of really thinking about patient care, devotion, but also a very talented scientist as we're really thinking about how do we move from implementation and deployment of the work and working with all of our partners. So with that, just as a reminder, if you're joining in today, name which organization you're with, and if you have any pressing questions, would love to see that in the chat. But with that, I think Dr. DeLay, we are ready to hand it over to you. And thank you for you and Dan both joining today. So Kelly, it's all you.
Thank you, Andy, and good afternoon, everyone. It's a pleasure to be here with you today. Thanks to Elsa and Andy for organization and Dan for being here. All right, let's get started on Barrett's esophagus. I have no disclosures today. So our learning objectives are to review the risk factors for Barrett's esophagus and esophageal adenocarcinoma, to understand which patients should undergo screening for Barrett's esophagus, to discuss non-endoscopic methods of Barrett's esophagus screening, and review principles of endoscopic treatments for Barrett's esophagus. I'll primarily be using the guidelines published by the American Journal of Gastroenterology in 2022 with Shaheen and his group on diagnosis and management of Barrett's. So we will start with a case. Most importantly is the patient. 67-year-old male, Caucasian male with history of tobacco use, class 1 obesity, long-standing reflux symptoms, who is referred for an upper endoscopy with dysphagia as his primary symptom. And so this is unfortunately not a site that's unseen to my eyes. We go in for upper endoscopy and we see cancer in the esophagus. And so even without these biopsy results, we know with this type of history that the diagnosis is most likely esophageal adenocarcinoma. And esophageal adenocarcinoma has increased over 700% in the past 4 decades. It's the #1 rate of increase of any cancer. You can see profoundly that increase on the graph on the right as compared to other more common cancers. And estimated new cases of esophageal adenocarcinoma in 2023, 22,000. It was about 1% of all new cancer cases, estimated deaths 16,000, and it was about 3% of cancer deaths, with a pretty dismal 5-year survival rate of about 20%. So Barrett's esophagus is the only known precursor for esophageal adenocarcinoma. When detected early, patients with Barrett's esophagus can undergo either surveillance or highly effective treatment. But unfortunately, over 90% of patients with esophageal adenocarcinoma never knew that they had treatable Barrett's esophagus. So let's review what is Barrett's esophagus. So, the way that we describe it to our patients is chronic reflux changes in the esophagus that has developed over time, chronic tissue changes from that reflux. And so what we see endoscopically, if I can direct your attention to the right here, is that normal esophagus epithelium is this squamous tissue. It's light pink. And what clues us in beyond risk factors to Barrett's esophagus is this salmon colored or darker pink colored tissue in the lower esophagus. Barrett's esophagus is a change in that tissue to columnar epithelium with intestinal metaplasia and goblet cells. And we have to biopsy that and prove that the goblet cells are there for this to be a diagnosis of Barrett's esophagus. So by convention, you have to have either a centimeter or more of this tissue change in the lower esophagus. Less than 1 centimeter of this tissue change is very common, and the risk of that progressing to anything clinically significant, very low. So for Barrett's esophagus, to undergo surveillance, to undergo treatment, we always want that 1 centimeter or more based on the endoscopy findings. So there truly is a spectrum of disease. We have non-cancerous or non-dysplastic Barrett's esophagus. We have an indefinite for dysplasia that we can see on those biopsies. That's often related to active reflux-related inflammation, We have low-grade dysplasia, high-grade dysplasia, kind of on that continuum to esophageal adenocarcinoma. So today we're going to run through screening, diagnosis, surveillance, and management, and really flesh these out. So Barrett's esophagus prevalence without any GERD or risk factors, 0.8%. GERD alone, 2.3%, still low. GERD plus 1 risk factor, 12%. But when we look at GERD plus 3 risk factors or more, we have a prevalence of about 15%. So pretty high prevalence in this patient population. But we know actually that the Barrett's esophagus screening rates are very low. So when we look at this high-risk population, males over 50 with 1 risk factor, and chronic GERD as a history, actually less than 10% of these high-risk patients currently undergo upper endoscopy screening. So screening, we suggest, based on our guidelines, a single screening endoscopy for patients with chronic GERD symptoms and 3 or more additional risk factors for Barrett's esophagus. The risk factors for Barrett's esophagus, as you all know, male sex, Caucasian, age greater than 50, central obesity, history of tobacco use or current tobacco use, and a family history of Barrett's esophagus or esophageal adenocarcinoma in a first-degree relative. Upper endoscopy remains the gold standard method of screening for Barrett's esophagus. We also have unsedated transnasal endoscopy. It's great for patients that want to avoid sedation and do a lunch hour procedure, but fairly poorly tolerated. And so we often don't do this as much as our upper endoscopies. And then we have newer modalities. And so our GI societies, the American College of Gastroenterology and the American Gastroenterological Association, has looked into and released guidelines in using non-endoscopic screening methods for patients that meet criteria for Barrett's screening, and have kind of fleshed out some of the technology in progress and already FDA approved for screening and to improve screening rates for Barrett's esophagus. So they suggest a swallowable non-endoscopic capsule sponge device combined with the biomarker as an acceptable alternative to endoscopy for screening for Barrett's esophagus. So what are these devices here? So we have a few options of swallowable cell collection devices. You can see pictures A, B, and C are actually a sponge. So it's a sponge within a capsule that once swallowed is dissolved, and then that sponge turns into an enlarged sphere. And then as it's attached to a string, we can pull that string through the lower esophagus and collect cells. Similarly, pictures D and E are actually related to the ESO check device, and this is a silicone balloon. And same concept, it's swallowed, the balloon is inflated and then withdrawn through the lower esophagus, collecting cells. Samples are then used for the assessment of biomarkers associated with Barrett's esophagus. So there's either a protein marker expressed in intestinal metaplasia called trefoil factor 3 or methylated DNA markers. We are currently using ESOCheck in our GI clinic at the University of Colorado, the Anschutz campus here. And we are ramping up with our internal medicine department, who have also been credentialed for this procedure to be carried out. So the ESOCheck capsule is about the size of a daily vitamin, attached to that string, and after a patient swallow, we inflate the balloon, we pull that through the lower esophagus, we invert the balloon back into the capsule, and then just clip off that end, that capsule, to send off for testing. And so we use next generation sequencing to examine these different gene locations for markers of high risk for Barrett's. And so this is an in-office 2 to 5 minute procedure, unsedated procedure, and most often carried out by non-physician colleagues, non-provider colleagues. And so a great alternative to folks. With a caveat that, just as with Cologuard or FIT testing, if you have a positive test, The recommendation is to move forward with an upper endoscopy for direct visualization of the tissue. The results come back as a yes, abnormal cells, or no. And if it's a no, then that patient has been screened for Barrett's esophagus and there's no need for repeat screening. Other options, TissueCypher. This is an AI-driven precision medicine test. It predicts the risk of progression to cancer in patients who we know have Barrett's esophagus. It's performed using biopsies that are obtained just during routine Barrett's esophagus screening. And this addresses the limitation of dysplasia grading as a predictor of progression to cancer. And so it identifies molecular signatures, predictors of progression that even precede the development of dysplasia, with the goal of allowing for earlier identification and treatment and management of these truly high-risk Barrett's esophagus patients. Future investigations, some really interesting technology here. The esophageal capsule endoscopy, this is much like the capsule endoscopy we already have for looking and evaluating the small bowel, but this is looking in the esophagus that needs a little bit more tech advancement for active use. We've got tethered capsule endomicroscopy. This captures cross-sectional images using microscopic technique. Exhaled volatile organic compounds. We know cancerous and precancerous cells exhibit different profiles, organic compound profiles. This is actually a handheld device that patients breathe into and out of for about 5 minutes. And then, of course, another really exciting area, the esophageal microbiome. Normal distal esophagus microbiome is altered in Barrett's esophagus and reflux esophagitis. And so this is an area they're looking into yet. None of these ready for active use, but pretty exciting, and we should see some of these in the future. Of course, Dr. Wani here has active studies. The first is the Cited Detect Me study. This is using the Endosign cell collection device. This is a sponge device for detection of Barrett's esophagus and esophageal neoplasia. And then we also have the EsoCheck study. This is a detection of Barrett's esophagus using that silicone balloon EsoCheck technology in patients without chronic GERD symptoms. And so this is patients over 50 with the absence of weekly heartburn or regurgitation, not on medications for GERD. So if you have any patients that you're thinking of as we have these studies and they're interested, please let us know. Surveillance of Barrett's esophagus. What do we do when we have this diagnosis? So non-dysplastic Barrett's esophagus, we separate into segment length less than 3 centimeters and more than 3 centimeters, or I should say 3 centimeters or more, with the knowledge that longer segments of Barrett's esophagus are associated with higher rates of progression to neoplasia. And so for non-dysplastic Barrett's less than 3 centimeters in length, we repeat an upper endoscopy for surveillance in 5 years. And patients who have Barrett's esophagus greater than 3 centimeters, that's non-dysplastic, we repeat the upper endoscopy in 3 years. And generally, based on these guidelines, although it's expert opinion still, all that we have really is the chemo prevention as pharmacotherapy for patients with Barrett's esophagus. And so we do recommend at least a daily dose of a PPI, proton pump inhibitor, or a PCAB, the potassium competitive acid blockers, for patients if they have active esophagitis. Then we will recommend higher doses of those medications, but at least a daily PPI or PCAB with the diagnosis of even non-dysplastic Barrett's esophagus. The risk of progression from non-dysplastic Barrett's to esophageal adenocarcinoma, 0.6% per year. Low-grade dysplasia, Barrett's with low-grade dysplasia is 1.7% per year. This varies widely depending on the study that we're looking at because of different study designs. So it could be even as high as 13.4% per year. And the risk of progression of high-grade dysplasia to cancer is 5 to 8% per year. All right, so let's go into what do we do when we have management of Barrett's esophagus that's different than just the non-dysplastic. So management of patients with Barrett's with low-grade dysplasia. The ACG recommends endoscopic therapy, which is endoscopic eradication therapy. That's what EET stands for. In patients with Barrett's esophagus with confirmed low-grade dysplasia to reduce the risk of progression, with endoscopic just surveillance alone, so not the endoscopic eradication therapy, as an acceptable alternative. And so this is the ACG guideline. The AGA guideline does recommend in patients with Barrett's esophagus with low-grade dysplasia they do recommend endoscopic eradication therapy over surveillance. So getting rid of that dysplastic segment and getting rid of the Barrett's esophagus. However, patients who place a higher value on the well-defined harms of intervention and lower value on the benefits regarding reduction of esophageal cancer mortality, which are indeed uncertain, could reasonably select surveillance endoscopy alone. So not pursuing eradication therapy and just doing intermittent upper endoscopy for surveillance. So it's not only patient dependent, but it's also dependent in making sure that the diagnosis of Barrett's esophagus with low-grade dysplasia is indeed confirmed. It's part of guidelines for 2 expert GI pathologists to agree on a diagnosis of Barrett's esophagus and any dysplastic component. So anytime we have a referral, our first step is to always make sure our pathologists agree with the outside pathologist diagnosis, and that we really have cemented the correct diagnosis for patients, as it can mean endoscopy in 3 years versus an intervention to treat dysplasia. Patients with high-grade dysplasia or esophageal adenocarcinoma, basically the AGA and the ACG, our major GI societies, recommend endoscopic eradication therapy over surveillance. So doing something in patients with high-grade dysplasia or IMC, intramucosal carcinoma. So the principles of endoscopic eradication therapy, or EET, is to endoscopically resect all visible lesions. So we often see a Barrett's segment with nodularity or precancerous areas. And then to ablate the remaining Barrett's esophagus segment, we use either radiofrequency ablation or cryotherapy. And then we repeat this endoscopic eradication therapy with the goals of treatment being complete eradication of any dysplasia and any intestinal metaplasia or Barrett's tissue. And then that's really not the end. Once we achieve those goals, we still put patients under surveillance to make sure that they don't redevelop any Barrett's changes or dysplastic changes. Important to note, though, that for patients undergoing endoscopic eradication therapy, data do show that treatment at high volume centers is associated with better outcomes. And so when you're thinking about referring a patient with these kind of diagnoses, you want to make sure you're referring to often a tertiary care center where they have a lot of experience in these types of treatments, as the data show better outcomes with that. So our take-home points today: identify at-risk individuals for Barrett's esophagus and screen them. Any screening will do. So non-endoscopic screening tests versus upper endoscopy will take anything. Perform high-quality exams at high-quality centers. Manage certain components of Barrett's esophagus, like low-grade dysplasia, using a patient-centered approach and making sure expert pathologist opinions agree. And then consider referring patients with Barrett's esophagus, high-grade dysplasia, or intramucosal carcinoma to a high-volume center to pursue these endoscopic eradication therapies. We ideally want to prevent any Barrett's esophagus from transforming into this ugly esophageal adenocarcinoma. That's always our goal. Thank you so much.
Excellent. Thank you, Kelly. Super helpful. We're going to get Dan ready to rock here in just a little bit too. But Kelly, I know that many of the people that are joining today are part of FQHCs, rural health centers, critical access hospitals, and many of the patients that we all work with through CCSP and the like. For follow-up colonoscopy or even for a workup of GI, like an upper GI test and study, it's difficult. And so I really have felt that the non-invasive testing, so what we've done in colorectal cancer with stool testing and the variety, and you've talked about what's on the horizon. But as I understand it right now, as you're working with Lucid and others to really help primary care really build up that capacity, can you talk about, even for the medically underserved and uninsured patients and people who don't have resources, what's out there right now for these testing options and that our FQHCs and rural health centers can be considering?
Yeah, I think, to speak to what you were discussing earlier in terms of some government funding and support for these types of interventions, right now, Lucid is billing patients if they are insured, but are currently covering the cost for these tests as they get ramped up because they want people to be using them. And so they're in a great period of time for collaboration. But in terms of the other, non-invasive methods like the sponge, we've got these studies to get people enrolled in, but we don't have yet any well-defined kind of insurance-related reimbursement. As these studies progress and are used, that will get flushed out. But
Mhm.
currently, we don't really have that.
Mhm.
And so we're kind of in this hole where we're relying on funding or the companies themselves to help basically cover that cost of these tests.
Okay. And Lucid actually is doing a lot of that. I know Exact Sciences is doing it for colon rectal, but Lucid is really looking at how we can do that as well. And I bring this up partially, and I think at the outset, with funding from the Rady family and with the Rady Center work, Kelly, I think one of the big missions of that family who was impacted by esophageal and cancer is really thinking about early detection, prevention, and really, if there is a diagnosis, like earlier staging and really looking at delays in care. So I'm excited that we have some pilot funding right now. We'll be starting this summer with Keefe Memorial Hospital, Salute Family Health Center, maybe some of these UC health sites to start looking right at stronger integration of what do we mean when we say GI screening. So that will include, the esophageal, the gastric, incomplete with also the colon and rectal. And I think Lucid, providing those tests for people who aren't insured, as well as them and you and other experts really thinking about what does it mean to build that capacity and how do we use these new technologies or, technologies that are somewhat maybe kind of those of us aren't, we're a bit more naive. So I'm excited about this work just for our CCSP friends and many of our partners. We're going to start working on these sort of initiatives with a couple of pilot tests. But again, I think Kelly, as you said, in addition to funding for the testing, and really looking at how do we build out opportunities for the clinical care. We really want to do more around the implementation so that these really do fit within workflows, education for navigation, education for patients. So we can do much like we've done for colon and rectal cancer, but for gastric and GI. And Kelly will be a leader in that work. And so, Kelly, I really appreciate this. And I know we're going to take the show on the road and be doing a lot of this kind of work. So thank you so much for your support and building out that capacity. And everyone, I think as we're growing and learning about this, we'll be sharing about these implementation practices, how it's going at these sites, and then really maybe think about how we build that on with future work of CCSP and funding mechanisms. So thanks. And then anyone, if you have questions, please, Kelly will stay on with us and we'll have some open discussion. But I do think that access to care is huge. So thank you so much. And Dan is all ready to rock. So I just want to say I had a pleasure of meeting Dan and his wife about a year ago when we actually had an opportunity to talk about the impact of donor and donor relations at CU and talking about the work that the Rady family has provided to Dr. Wani and our whole host of associate directors and really thinking about implementation. But I actually have to tell you, I learned so much from Dan around really the power of prevention, his experience, maybe some of those opportunities. And when I got to spend the evening with Dan and his wife, we had an amazing time. But I think really being educated about his experience has really stuck with me. And so we're giving Dan a hard time before this that he's become a bit of a superstar. So he's on stage, he's getting blogs. We think there's probably a TV contract at some time. But all to say, I mean, not to make light, I mean, it was a pretty difficult situation. And I think Dan, being able to share your story and talking a little bit about care. And I do again think really what do our communities need to know as we're deploying these sort of strategies is really imperative. So I'm going to turn it over for you to you, Dan, to really talk about, I think, an overview of who you are, what's your experience, how treatment and diagnosis came. And then again, I think if you could really be the foremost experts on what we should know as we're thinking about building programs and really thinking about esophageal screening, I think it would be marvelous and so glad to have you here. So I'll turn it over to you.
Thank you for having me. Um, with my experience, I'm a 20-year Army vet, 4 combat deployments. So with the burn pits, that was number one indicator for my primary care doctor. I also smoked and used smokeless tobacco throughout pretty much my whole entire career. So that was 3 factors. I was overweight, so that's 4. I wasn't over 50 at that point in time yet, so thank goodness for that one. I didn't meet that criteria, but I did have a lot of indicators going on. I had GERD for many, many, many years, to where it would wake me up at night. And I would throw up just stomach acid and everything else, almost black tar looking stuff. And my primary care doctor, um, she gave me antacid medication and everything else, but she also kept it in the back of her mind that I had all these things that could eventually turn into Barrett's esophagus. So she called me up one day and was like, "Hey, we got this team of people coming in, that have this little capsule that you can swallow and they blow it up and everything else." And I was like, "Well, let me talk to my wife and see, what she thinks." And because she is the boss, and she told me that I was going to do it. So I went and did it. And thank God I did. I get emotional. So I tell everybody it's 5 minutes for the rest of your life. And it was literally probably 5 minutes of swallowing this little capsule, having them blow it up, take it out. And then to get the call that I had at normal cells, really didn't think much about it at first. Went and did a endoscope here in Colorado Springs, Colorado, and the doctor who did that found Barrett's. Said I had a couple of lesions, and then referred me up to Dr. Wani at Anschutz. And when we got up there, I was going to do the treatments that Kelly was talking about, as far as I think it's the EET treatments. But when Dr. Wani got in there, and this was a matter of months, so my diagnosis was in October of 2024, and in January of 25 is when I went and saw Dr. Wani. From that time, from October to January, it had turned into stage 2 cancer in that couple of months, which I didn't know, but was what was supposed to be a 45-minute procedure turned into a little over 4 hours. So when I came out of anesthesia and everything else, Dr. Wani was standing there talking to my wife about everything that was going on. And uh, after that, of course, I had to go back after he removed the cancer and they sent it off to pathology. Came back that it wasn't deep tissue, thank goodness. And had to do endoscopies after that as well. So I think it was 2 months after the initial, and then like 3 months, and then it was 6 months. And then now I do it every single year. I go in and get my scope done to make sure that nothing has come back. Um, as far as how it's affected my life, I weighed about 255 pounds when all this happened. Since then, I'm down to 175. So I started taking better care of myself. It is a wake-up call. Um, the only thing that I could say to any providers that might be on this is, if you have patients that have GERD, or not necessarily have GERD, they could just have acid reflux, and they meet the criteria, or they hit the check marks like I did as far as being a tobacco user and everything else. The test that I took, the EsoGuard, was simple. The worst part was the gag reflux when you swallow it down. It's not like taking a pill where you just swallow it and it goes. Like, they have to feed it in. So that was the worst part. It was the worst part. And if you can get past that, then like I said, it's 5 minutes for the rest of your life. And I owe everything to that.
Thank you, Dan. I think that's, really amazing. And one of the things that I just wanted to say is I do think, we've heard, I was just in a meeting last week around navigators really thinking about folks who really are at risk, right? But I think we hear things about firefighters. I think we hear things so much about even people who are in the military and at this increased risk. And, Kelly, I think one of the questions I have, right, is we're thinking about all these environmental pieces, and, we have that list of what those factors are. So, I mean, Dan, you were, like you said, you were smoking at the time, you had GERD, you had all of those symptoms, and then, some of the known entities. But Kelly, one of the questions I've had too is we're really kind of looking at these
Can I say something
exposure.
real quick?
Sure, yeah, go ahead.
So I had stopped smoking and chewing for over 10 years. When I met my wife, she said, "You're not doing that anymore." And I said, "Okay." And then we got married and everything else. So this is 10 years after the fact of me
Mhm.
smoking and chewing, and 12 years after the fact of me being retired out of the military that all this came about.
So it really was kind of an after. Okay, so this is really after the fact. Kelly, one of the questions I think people and I hear come up is also this environmental piece for people like Dan, right? I mean, Dan, you were really part of burn pits. I mean, you were there, right? Active duty in that kind of environment. Is that what I understand as well?
Yep, 100%. Wherever we put down our roots, which we called fobs, we had burn pits. There was no other way to get rid of the trash and
Hmm.
hazardous material that, that we were around, so we burned it.
Hmm. Kelly, with firefighters, people who are in the military who have these sort of exposure to like fluorocarbons and then toxins, is that something that's coming up too, Kelly, as a potential risk and maybe even thinking about how we treat sort of people who are susceptible based on environmental and kind of their employment factors?
Yeah, I mean, I think it's a great point. We don't have the data to show it yet, but I know it's in progress too. And the VA is partnering with Lucid as well because of so many veterans with these types of exposures, Dan. And so they're reaching out into that community as they've done with firefighters for the last couple of years now. It's not flushed out in the guidelines yet, but when you think about these types of populations and who's has served or has these exposure, a lot of them are hitting the criteria even without those additional exposures as well. Yeah.
Hmm. Right, multifactorial for all of these pieces as well. I'm going to actually give a minute because I always have a million questions and ideas about things we could chat about, but I'm actually just going to give half of a second to ask anyone who'd like to come on mute to come off mute to please unmute, raise a hand, and we'll also be looking in the chat. And I don't know, Elsa or Joe, if you've seen any questions as well.
Yeah, we haven't received any specific questions in the chat yet, but if you'd like to come off mute, that option is in your toolbar on the left corner. So you can unmute if you'd like, or if you want to take the time to put something in the chat, we'll make sure to address it as it comes in too.
Okay, Kelly, Dan, while we're getting people rocking here, and I know Heidi from Keith Memorial and Tamala from Keith Memorial are on today. I do think, Dan, the one thing that you've mentioned is, just calling it out is that in some degree, the swallowing piece, right, of the test, right, that's people are saying like, oh, that can be difficult. And I love the way that you frame it to say it is 5 minutes. And, it's something that really can help. I mean, really think about, a strategy, for really thinking triaging patients who do need a scope later or, the like, that it's one of the opportunities. Kelly, I guess one of the questions I have as well is for you, who's really looking at this and as we're thinking about the implementation and what you're learning. I mean, how big of an issue is it? And is the technology like in the next couple of maybe years, Kelly, getting that they actually non-invasive and the swallow component of that, is it going to get better? I know you alluded to that, but I do think that's one of the barriers around this sort of technology right now is people, saying that it's a sizable, it's a hard pill to swallow, like literally. So, Kelly, anything that you're seeing and Dan, anything in addition, but Kelly, I'll start with you.
Yeah, I mean, I think the early versions of the Cyto sponge too, even the updated version, the Endosign, the sponge is smaller. So I think that's just like everything, our phones are getting smaller and technology is getting better and smarter. With the addition of AI, tissue cipher, different biomarkers that we're using, even serum tests that they're looking into for markers, increased risk for Barrett's. I think the future is to use a kind of a multitude of those tests together. So I think, technologically, I'm sure this little balloon will get smaller, but big picture, I think we're going to be even have non-invasive, even these non-endoscopic, non-invasive tests. I think it's going to become even less invasive with that, with the blood tests that we're looking at and the AI technology, microscopic way of cross-sectional imaging. We're going to be putting all of those together.
Hmm. Great. Dan, anything else you want to say about the pill? I think, again, you've said a lot, but anything else you'd want navigators or primary care folks to think about with this?
But I want to emphasize that the gagging is the worst part, but it's quick. I mean, it's really fast. It didn't bother me at all unless somebody who naturally has really easy gag, reflex and all that stuff. But for me, I gagged 2 or 3 times and they were feeding it down, so and then when they pulled it out, it was nothing. There was no gag or anything like that. So it wasn't bad.
Hmm. So Dan, I mean, now that we have so many of the partners and folks that we're going to be working with, I guess any
Mhm.
additional insight, I think, as people are doing general education in their communities or even interfacing with people one-on-one. Um, Sounds like your wife was a great motivator. I mean, honestly, she's like, stop smoking, get fit, we'll get married. We're getting
Yes.
married, you have these things to do. So this woman is a powerhouse, which I think many of the people, we hear that. And I met your wife, and she is lovely, and we had an amazing time the evening that we got to meet. But I guess, for kind of drilling that down, right? When you think about your history where you were, and then
Mhm.
even thinking about with many of our primary care clinicians who are on today, I guess what would be some additional words of advice as people are interfacing around esophageal cancer, as well? Anything else you'd like to share with the teams?
Um, I mean, you don't know until you know. Um, that's the biggest thing. I never would have thought in a million years that I would have had esophageal cancer. It's not in my family. Cancer's not in my family.
Hmm.
Nothing like that. So it never crossed my mind. Um, I really didn't have a ton of symptoms. GERD was really the only thing I had. So, um, just knowing that my doctor was looking out for me was
Hmm.
the biggest thing because a lot of times, especially veterans, we don't look out for ourselves. We don't go to the doctor. We don't go to the hospital. We don't do our normal checkups, things of that nature. So to have an advocate in my doctor who's
Hmm.
looking out for me saying, "Hey, you should really do this," that meant the world to me. And I mean, essentially saved my life. So,
Hmm. And as we're also thinking about this in your journey, right? I mean, you talked about with the surgery with Dr. Wani, right? And where you were.
mhm.
I'm just thinking in Eastern Colorado of two gentlemen that I know right now that are actively going through esophageal treatment. And some of the people who I think are on the phone, right, are providing care to these individuals, are helping kind of look out. Based on your experience in your treatment journey, I guess anything else that you'd like to share or even advice for clinicians, based on your own experience, because you've done well, but doesn't mean that it's been easy and that there aren't things that you don't probably deal with every day or that you deal with every day that, aren't probably clear, from people looking or just having a conversation with you. But can you share a little bit about Dan?
Yeah. So the procedure itself, like I said, I had no idea um, that I was under for a little over 4 hours. I thought I was going in for a 45-minute appointment. So that realization for me wasn't there. Robin, my wife, would be the person to talk to about that because she was the one who was sitting in the waiting room wondering what was going on. Um, but as far as the treatments afterwards, they're fairly quick. Of course, you go under anesthesia and they do what they got to do. I do take prescription strength antacid twice a day, once in the morning, once at night. Um, I avoid spicy foods as much as I possibly can. Um, I've taken out a lot of the risk factors in my life to make sure that this doesn't come back. And that's the thing, as a patient, you have to, once you find out you have this, and if it is curable and you can get it taken care of, then you have to help yourself. If you don't, then I mean, the likelihood of it coming back is probably pretty high, considering how esophageal cancer is now.
Hmm. Exactly. And I know, Kelly, you work mostly on the prevention and the screening side, but we do have, some of our team, Sasha and Wani, who's part of the treatment, and interventional team, and all. And I think Kelly, from a provider's perspective, I mean, even thinking about that maintenance and routine screening, anything else to share, even about, post-diagnoses, Kelly, anything you want to share?
Yeah, I mean, I think, and this comes up a lot, in that people are afraid to take long-term PPIs, chronic PPI use or PCAB use. And insurance sometimes won't cover them either, so it can be a cost issue too. So we often see patients come back for their surveillance, and in the interim have either self-discontinued or someone has discontinued their treatment. And even though the data aren't great, it's really the only chemo prevention that we have. It's the only real medication that we have, in addition to surveillance endoscopies, to decrease the risk of ongoing inflammation from that acid. And so
Mhm.
I think, big picture for patients with Barrett's esophagus, the benefits of these therapies, even though there are some side effects, um, highly outweigh any risks. And what have been borne out in the studies for risks of these medications are really the risk of gut infections from kind of messing with that pH balance, that acid-base balance. So increased risk of bacterial overgrowth of the small intestine, increased risk of C. diff. The other kind of scary commercials about heart disease and kidney disease, and dementia is pretty much debunk is that yes, there is an association. People are on these medications and they also have developed these diseases, but they also have high blood pressure, high cholesterol, diabetes, family history of dementia. And so you can't really say, oh yes, they were on a PPI and they developed these diseases. So I think big picture is that these medications are important to continue. The risks don't outweigh the benefits that we get from them. And ongoing inflammation, especially even after you've had endoscopic eradication therapy, for which stricture or stenosis of the esophagus can be a side effect or a complication, ongoing acid exposure to that area can actually even increase the risks of the post-treatment complications. So just something to think about, on the front lines and dealing with all these patient questions about risks of medications and PPIs in particular.
Perfect. So Kelly, you as a clinician really come at people from all the sides, from the up, the GI from the upper, as well as doing colonoscopies from the lower, right? I mean, you're a GI doc extraordinaire. Let me ask this because I think, this is one of the things, and Dan, I didn't want to put you on the spot to say, are you up to date with your colorectal screening as well, right? But Kelly, I think so many of the folks we chat with through CCSP, we'll also talk about patients who have, they have issues around GERD, but they have issues with GI bleeding and they have issues with bowel and they have, all of the things that are a lot of kind of GI at large symptomatic piece, right? And in trying to kind of figure out what's going on. And so I feel like a couple of our clinics have said, we have great resources for colorectal screening, although, they're not always expansive. We can't get everyone always a colonoscopy in the timely fashion we'd like. We don't always have all the treatment readily at hand, but we're getting a better grasp at building in population approaches for screening, education, early prevention. And they're like, that's great. And I think so many people on the phone today right now said, but when we rule that out, right, these individuals, we know it's not GI, colon, and rectal. It's not a cancer. There might not even be IBD or whatever. And then so we're at this point where we're kind of ruling it out that is it gastric or is it really looking at esophageal? So I guess, any advice, and I don't know, this is kind of a big kind of fuzzy question, but like when we're really thinking about so many of our teams are out there with patients who have a variety of GI symptoms and they're really thinking of where to start or what to do and like kind of how to help patients as we're not just talking about one body or one organ site. I guess any words to the wise of like how to decipher, right? What is it? Is it lower? Is it upper? Or, is the best message just start with a place for screening and then kind of rule out? What would you recommend?
Yeah, I think the latter, actually. I think the way that we've partnered with EsoCheck, EsoGuard, the Lucid Diagnostics team, in one of the avenues is to start screening patients who are coming for colonoscopies, for just screening colonoscopies and see if they meet criteria for the EsoCheck as well. And so
Mhm.
I think starting to marry those two together, especially in the area of the country where we live, where so many people are going to meet the criteria for Barrett's esophagus screening, starting to think about, at that age 50, that we're starting to say, okay, we have colon cancer screening we need to check off, and Barrett's esophagus screening because you have these risk factors too. And like I said, Sachin, Dr. Wani is already doing a study of people in the absence of reflux symptoms for a variety of reasons. Patients might not report it. They have good control on PPI, so they don't feel like they have reflux anymore. So for all those reasons, kind of throwing a wider net about what should be screened at the same time. And if we start to marry EGD and colonoscopy, we might be able to capture more of those people in our initial exams. In terms
Right.
of parsing out upper GI and lower GI symptoms, the actual cancer symptoms differ significantly, but that's why it's too late. And so that's why I think we take it back 3 steps and start to screen at the same time, upper and lower.
hmm I get this question a lot. People say, can you do an upper GI and a colonoscopy all at the same time if you needed?
You can do it at the VA. I used to work at the VA, and because of, their insurance model there, yeah, you can add it on. We
Right.
struggle here at the university because we have to have insurance pay for it, and often they will.
Mhm.
But the patient has to sign a waiver that if insurance won't retroactively pay for it, that they will, and that's kind of a hard pill to swallow as well. So it's harder to add on the spot. It's better to scrub schedules and with the initial order for the colonoscopy, put in that order for the upper endoscopy at the same time instead of on the day,
Mhm.
switching the plan.
Right. And I oftentimes have to remind people it's not the same tube that goes the whole way because there's other organs that really, so just for our friends at home, and I know we know that, but I swear I get asked that at dinner parties or happy hours or, later in the evening, sometimes after gatherings. So I always think it's really interesting. But I mean, these are things that really, I think it's education, right? Knowing the anatomy, knowing what's available. So Dan, let me ask you a question other than have you had your colonoscopy as well? But if you want to answer that, great. If not, that's fine. But Dan, one of the things and we've talked a little bit, and I think with the Rady Center particularly, I really have enjoyed our discussion, and we've done this with colon and rectal a bit, and we should probably do more, but we talk a little bit about the psychosocial impact of really thinking about a diagnosis and being past that part of treatment and screening and diagnoses. But when you really think a little bit, and I think particularly for males and men in rural communities or, in lines of work where, right, the orientation is, kind of a military and a strong and keeping like a stiff upper lip and that sort of feel. I guess from the psychosocial component, Dan, and where you think you are now, and even for all of our primary care teams to think about post-diagnoses, what do you think the things that folks really need to consider for their patient population? Any words of wisdom or any supports that helped you?
No, I mean, every time I tell my story, I break down. Um, I did 20 years in the Army. I'm that tough guy that you're talking about. But I love telling my story.
Mhm.
Anybody I talk to, if they talk about them having stomach issues, anything like that, I bring up the stuff that's out there. Like you go talk to your provider and see if they have, the ESO check and all that stuff and see if you can get that done. Anything, even if it is an endoscopy, go get it done just to make sure, because if you don't catch it soon enough, it's gonna get you. And I've met people when we did the not the gala, but when we did the symposium, and I was a guest speaker there. I met two gentlemen that have gone through the surgery and everything else, and it does not look fun. It doesn't look pleasing, and they even told me that it's absolutely miserable. They live a great life right now, but leading up to that was absolutely miserable. So, and for the people, the men that are out there that think they're too big or too strong, it changes when cancer's in the picture. I mean, it really changes your life.
Absolutely. And today I will actually send on for probably CCSP partners, people attending as well, the CU support groups that I think even many of them are virtual to be able to help support. But also know groups like Man Up to Cancer and others do a really good job of particularly, addressing some of the things that are, really pertinent to men. But there's a lot of really great support for men, women, people regardless of gender identity, of course, really wanting to talk about supports. So we will be sure to send those on as well. And we do have a clinician who's part of our one of the associate directors who's really delving into those supports and with all of our programs, hopefully trying to do more deliberate work around choices, really thinking about decisional balances, but also really then thinking about supports for people who are diagnosed. And hopefully, as much as we can, looking at integration for referral for services for all part of the cancer continuum, including mental and behavioral health. So With that, Elsa, I'm going to see and pause for any final thoughts or questions. I think I've addressed any that have come to me. But Elsa, Joe, anyone, and then I know actually Jessica Dry is joining us from the Cancer Center. Jessica, I don't know if you could come on mute, but also Dan, while we're maybe seeing if we have final questions, you mentioned the symposium, and I think this year the symposium was hosted in April. But Jessica, are you able to come off mute and maybe talk a little bit about the resources and the programming we have at the Cancer Center for the Rady Center Symposium?
Yeah, I can talk a little about it a bit about it. So, April, as you guys know, is Esophageal Cancer Awareness Month, and so it's our big month of the year where we do a lot of events that include the symposium, where annually we're able to present on the new research, the new clinical strategies surrounding care. We have a support group there with the patients and yeah, I don't know really know what else to say about it, but it's a really fun event. We have usually, almost, 50 to 100 attendees. We've really built a network where, we see consistently the same people. So, like Daniel mentioned, he met people when he presented, and so you find that support when you're there. Uh, and we would love for everyone to join and reach out to the center in general and where we could connect you with individuals who can help you depending on what your needs are. So,
Awesome. Very good. Thank you so much. All right, Elsa, and team, anything else? I know we have just a couple minutes before the top of the hour where we need to close. Elsa?
Yeah, I think we didn't miss anything in the chat, but just saw a comment come in from Tamala with Keith Memorial that's thanking Dan and our speakers and that the information was really helpful. So if anyone thinks of any questions that we didn't cover in our discussion, please feel free to reach out to our team or the Cancer Center team. We'll also share Dr. DeLay's contact information, the Cancer Center contact information. So happy to help field any other questions and make sure everyone gets the resources. But I'm also dropping in a link to the evaluation from our webinar today. And we'd love if you could take a few moments just to complete that. Let us know what you thought, and it'll also show up as a pop-up when you close out of this meeting. So really appreciate everyone taking the time to join us today during this very busy month.
Yeah, April seems to be crazy. And Kelly, purple is the color, right, for esophageal? Is that
Yes.
right? All right. So
Yep.
bust out that purple for the last week of April. And a million thanks for Dan, Kelly, Jessica, for all the support from the Cancer Center, Rady expertise, and then all of our CCSP partners, Joe, Elsa. It's really an amazing team, and I am so excited. What I'll say is it's funny as we were talking about the building out of these programs and the things we're testing, I'm reminded from many of our colleagues and professional partners that we are some of the first to really think about how to do this really together in more of a kind of multi-site and a multi-pronged prevention approach. So, it's interesting, right? It's cutting edge in its own respect, but moreover, I think it's about really responsible and comprehensive patient care, and that's really what it's about for our insured patients, our rural patients, our uninsured patients, everyone out there. So everyone, super excited about where we're going, and have a good rest of your day. Thank you so much for joining, and take care. Have a good one, everybody. Thank you for everything you do. Have a good one. Thanks, guys.
Thanks, Andy. Thanks,
Bye,
Elsa.
guys.
Nice to meet you.